Working in behavioral health or managing an organization in the industry can be challenging. Regulations are constantly changing, and staying compliant is harder than ever. That's where the Behavioral Health Association of Providers can help. BHAP is a national association for those who work in behavioral health or addiction treatment. One of the ways we serve the community is by offering educational opportunities such as CE-based webinars and our Certificate in Addiction Treatment marketing. BHAP also provides advocacy information so you can stay on top of new laws and regulations that will affect how you do business. Our members benefit from simple, effective, and relevant resources that keep you focused on what matters most, the health and well-being of your clients. Helping small and mid-market behavioral health providers access compliance resources and legal education, BHAP is the leading and unifying voice of treatment programs. You can find out more information, as well as sign up for our various newsletters, on our website, www.bhap.us.
Good morning, everyone. Hopefully the yard work outside my apartment complex isn't too noisy. I'm glad you could join us today. I have no control over that, unfortunately. Welcome to the webinar Advocacy Year in Review 2022. My name is Angie Fiedler-Sutton, and I'm with the Behavioral Health Association of Providers. And now it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is a founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the International Certification and Reciprocity Consortium, ICNRC, the California Consortium of Addiction Programs and Professionals, CCAP, and Faces and Voices of Recovery. With 20 years of policy experience and over a decade in behavioral health, Andrew is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office on National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse and Mental Health Service Administration, SAMHSA, and other federal actors. Andrew has written legislation and report language adopted by both the House and Senate Appropriations Committees and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and welcome all of you. I just have a few housekeeping notes. First and foremost, I am coming out of the tail end of my COVID infection, which has not been fun. So I may sound a little congested. I may have a little bit of a cough. I apologize in advance. I know you're taking your time today to join us, and you expect a quality presentation. I'm going to try to give it to you, those little mishaps notwithstanding. Second, welcome to my home office, where I've been doing most of my work for the past 3 years during said COVID pandemic. I always like to say to people, especially in this space that I work in, where fellowship is so important, I feel like I'm welcoming you into my home so you know a little bit about me. I'm a big fan of horse racing. You can see my painting in the background. I'm a big fan of college basketball. And many other things. So just a little bit about me, aside from the professional. I'd like to welcome all of you to today's webinar about policy over the public policy in SUD and behavioral health over the last year. And you can see from the title, full of sound and fury, signifying nothing. I'm going to get into that a little bit more. Seems a little foreboding, but I'm very, very particular about what I name my presentations. And I gave this one a lot of thought. So we're going to get into why, starting right now. One last thing, if you have any questions during the webinar, you are free to wait until the end, or you're free to type them in the chat. If I feel like it's worth answering in the moment, and I see it in the chat, I'll try to incorporate it. Otherwise, maybe we can get to it at the end. So let's begin. Speaking of the chat, I like to keep my members of the audience on their toes during their webinar. I know that if I just talk and you just listen, things could get a little boring. So I start with a quote. Life's but a shadow, a poor player that struts and frets his hour on the stage and then is heard no more. It is a tale told by an idiot, full of sound and fury, signifying nothing. So for 10 points, not that anybody's keeping score. Does anybody know where this famous quote is taken from? Feel free to put your answer in the box. Angie, you're a moderator, so you're disqualified, so I can't give you the 10 points if you do know. But if nobody else is going to answer, Angie, you could feel free to go ahead and type your answer in the chat box. So that is actually oh, Angie, no, it's not Hamlet. You were so close. It's the other tragedy. It's Macbeth. It's Macbeth Act 5. So so close, Angie. But it's Macbeth Act 5. So we're going to get into why this year in policy has been full of sound and fury, signifying nothing. I in Washington am flooded with data. I get information points from all over the country on the SUD overdose issue, on treatment issues, prevention, recovery. And I make the assumption that those of you outside DC know that things are bad out there, but I don't know if you know to what levels. I'm sure if I could ask any of you, how are things going in your community, you would know. But I find it necessary to clarify to everyone how bad things are nationwide. So I'm not going to read this to you. It's there for you to see, and this is being recorded, so you can go back to it at any time. But I know we hear the number of overdose deaths over the last few years has been hovering about 107,000. That's really a little low. Because if you take into account suicide, which is often brought about due to a complication from alcoholism or substance use disorder, the number actually gets significantly higher to 186,763. It's really hard to separate suicides from overdoses in terms of intentional, unintentional, because many states can't count it as a suicide unless there's a note. But we know there are a lot of overdoses that are suicides, and a lot of suicides are often committed by people who have trouble with an alcohol use disorder. So that 107,000 number that we throw around is unfortunately low. Data also takes a very long time to process, so we don't have the most up-to-date. But the rolling data we have from the CDC, which updates every month to give you a picture of the previous 12 months, so we can keep a rolling picture of the year, that has been consistently at about 107,000 overdose deaths every 12-month period for about the last 28 months. So yeah, things are pretty bad. You can see that bottom statistic where it's worse, West Virginia and New Mexico surpassing 100 deaths per 100,000 in a single year. So the rate has increased by about 30%. There's a lot of factors in play. Obviously, fentanyl is a large factor. We're going to talk about fentanyl in much greater detail a little later on, but fentanyl does play a large factor, as does the pandemic. The most recent numbers pre-pandemic that we saw in terms of overdose were hovering around 75 to 80,000. I believe in 2018, that number plateaued in the sense that it didn't get worse. For years, it was getting worse. It was climbing. In 18, the number stayed level, which isn't really cause for celebration, but at least we thought, okay, maybe we're on the edge of some progress. But when the pandemic came and the isolation really set in, SUD numbers really took off, especially fueled by alcoholism. So you can see that bottom bullet point there. Alcohol-induced death rates increased by 27% in 2020. all 50 states as well. A lot of what I do in terms of my policy work, both for BHAP and for other organizations, including CCAP, the ICNRC, even for Faces and Voices when it comes to peer recovery, and for other clients I serve around the country. One of the big issues I work on is the SUD workforce, where we are, as you all know, ridiculously shorthanded across the board, whether it be clinicians, peer support specialists, clinical supervisors, whatever it may be. And we're starting to see some data that could possibly help us address these issues. Right now, the only government programs we really see to assist with the workforce are loan repayment programs. And we're going to also get to that a little later on. But an overwhelming majority of counselors surveyed would pursue higher education if they receive tuition reimbursement. And a little more would strive to a higher degree if it would lead to greater compensation. So the loan repayment seems to address some of that tuition assistance. Of course, the loan repayment is not free. It requires service in an underserved mental health area for anywhere from 2 to 6 years based on the size of your loan repayment. And but there's a problem besides recruitment, and that's retention, and that's where salaries come in. All of the government programs right now are focused on recruitment, but the SUD workforce also has a retention problem. And it's no surprise to anybody that compensation and reimbursement is at the top of the list in terms of that retention problem. There was also a study out of Penn State where, again, low salary was a function of the low rates of reimbursement the drug and alcohol programs received from the state. No surprise there. And the quote I see at the bottom, I don't know if this is a accepted term anymore. The redheaded stepchild. When I was growing up, that was a pretty common term 40 years ago. The redheaded stepchild means, you know, the one who gets the least attention, the one who gets ignored. If that's not a phrase that's used anymore, please let me know. I'll find something else. But it's really summed up in that last sentence. We don't get respect from the insurance companies. And that's true. There's no denying it. In my work in Washington, when we say, oh, let's do this with Medicaid or let's do this with Medicare, no one stops to realize that the rates we reimburse at are still ridiculously low. And that is a holdover, in my opinion, and if I dare say my expert opinion, that is a holdover from the 60s and 70s when Medicaid was first brought into the system, and for decades after, the public health system and politicians were not really falling over each other to do more for substance use disorders. They would reimburse anybody who was willing to take it at any rate they were willing to take. As a result, it's the bottom of the barrel. It's the crumbs. And the reimbursement rates are too low for the training that our professionals have, for the work they have to do. And it's really just a holdover. It's all part of the stigma that we face with SUD treatment services. For decades, when you ignore a problem by not really enacting policies that will motivate people to act in a way that is ambitious and conscientious, they're not going to. We really need to get those reimbursement rates up to show that we value our professionals and will pay them at a level that is worthy of their training. So the low reimbursement rates are just as much a part of a problem as any other part when it comes to filling our workforce. The programs we do advocate for in Washington are somewhat well funded. I'm going to list a few in a little bit. And workforce, when we talk about SUD policy, workforce is in the mix. It gets more lip service than actual action, but that's in a better spot than we were, say, 10 years ago, where we had to actually, knock down the door just to say, hey, what about workforce? What about workforce? Now, when we see policies, new policies being developed, workforce is generally a part of it. The policies concerning workforce expansion are not necessarily the best, but at least we're part of the conversation. So there's been a little incremental progress. And so based on that, I want to let you know where we're going, not where we've been. We know things have been bad in the past. Let's talk about where we're heading in the future to see how much progress we're really making in terms of SUD workforce and other treatment policies. So here's what I find to be an interesting slide. And it's a point that you're going to hear a lot through this webinar. You'll see the title up top, Behavioral Health Workforce Development Programs. Now, I know this is BHAP, Behavioral Health Association of Providers. So behavioral health is an important term. But when you work in Washington and when you work in policy, everything tends to, at some point or another, get siloed. So if you are in mental health, you're going to look for policies that benefit mental health programs. If you're in SUD treatment, you're going to look for policies that benefit SUD programs. I'm fully aware of the crossover between SUD and mental health services. I'm fully aware of the co-occurring disorder. I'm fully aware of how they impact each other. That's not what I'm talking about. I'm not talking about the clinical side of things. I'm talking about the programmatic side of things. And when it comes to advocacy and when it comes to government programs, it gets very territorial. SUD advocates want programs that benefit SUD treatment, and mental health advocates want programs that benefit mental health treatment. So when you get a program that's labeled behavioral health, things get a little hazy. Do they mean SUD? Do they mean mental health? Do they mean all of it? So it's a really tricky thing to break down. So you can see here, of the 7,480 trainees in the Behavioral Health Workforce Development Programs across HRSA, which is the Health Resource Services Administration, about 50% get training in SUD, about 50% get trained in medically underserved communities, and there could be some crossover there. But only 38% plan to continue in these underserved communities. Now, the definition of an underserved community is tricky. Because an underserved community goes by defining how many professionals of a certain profession serve in an area. And it's usually psychiatrists and psychologists. So you can have lots of counselors in an area, but not a lot of psychiatrists and psychologists, and it could be considered underserved. You can have lots of psychiatrists and psychologists in an area and not a lot of counselors, and it could not be considered underserved. So underserved is a very tricky definition. I think of it this way. I think the entire nation is underserved when it comes to SUD treatment services and mental health as well. I have yet to work with a community anywhere in the United States, and believe me, I work all over the United States. I have clients in Connecticut, North Carolina, Texas, Louisiana, California. I work all over the country. I have yet to see a community that says, we've got all we need. Thanks, we're set. So when it comes to this problem and 107,000 overdose deaths every year, I'm going to go out on a limb and say the entire nation is underserved. So, that statistic's a little misleading in my book. When HRSA wrote its proposed budget, or what we call its congressional justification, and just a word here on the process, every government agency needs to have its yearly budget approved by Congress. It's called the appropriations process. In order to kick off this process, each agency submits to Congress what they call a congressional justification, saying this is how much we need to execute our mission and where we see problem areas. And it's the first step in saying where do we need increases? Where do we see like we've had enough? Where can we cut programs? So this is done way back in March or April, and it kind of kicks off the process. Actually, February or March. So the report estimated from HRSA that the demand for addiction counselors is expected to increase 21% in the next 7 years, with a demand exceeding supply and leading to a deficit of addiction counselors of approximately 13,000 fully trained FTE, fully trained experts. I think that number is a little low. I have seen numbers from the National Bureau of Labor Statistics that show as much as a 20 to 30,000 shortfall. So I think that 13,000 number is a little low. But at the very least, we have HRSA saying to Congress, look, there's a shortfall of experts in addiction treatment. HRSA's main program to address this is called the STAR Loan Repayment Program, Substance Use Disorder Treatment and Recovery. So this came into being about 3 years ago. It was originally supposed to be funded at about $25 million. It wasn't. Congress, I can do a whole separate webinar on the appropriations process. This is not the, I don't have time to explain it inside of this webinar. But it originally started at only $10 million. Then it got up to $12 million. The House Appropriations Committee this year said they'd like to see $28 million, which is welcome news. We still need more, but when you work in advocacy, you kind of split your time between I'm mad I didn't get what I wanted and I'm glad I got what I got. This is progress, and advocacy is very, very slow progress. I've always said advocacy and recovery are almost the exact same thing. Even though I'm not a person in recovery, I do work in the recovery community. And what do I hear? You know, it's something you have to work on every day. And there's going to be good days and bad days, but you're going to get through it. You're going to, you know, work the process, and you're going to reach your goals. So this is small incremental progress to see the House recommend $28 million for this loan repayment program. Just a word on this. This is not only for counselors. This is for anyone who wants to enter the field of SUD services. Peers, doctors, counselors, psychologists. If you're going to commit to working in SUD in an underserved community, you will qualify for this loan repayment program. So. Another thing about Congress and the legislation that they passed to fund SUD treatment is the, excuse me, State Opioid Response Grant, SOR, the State Opioid Response Grant. Now, this grant is 5 years old. It started at $500 million a year for every state to do with as they please in response to the opioid overdose emergency. It has evolved. The states, I believe, are no longer limited to just opioid programs. I believe money can now be spent on stimulant treatment. I believe it can be spent on alcohol treatment. And the states can pretty much spend this any way they want. They can spend it on workforce. They can spend it on recovery. They could spend it on sober housing. They could spend it on any number of things, as long as it's going towards improving the SUD treatment and recovery situation in a state. But because it's 5 years old, Congress has to go through something called reauthorization. And this is an opportunity for Congress to kind of redefine the parameters of a program. They say, okay, this is what the money can be spent on. This is how much the Congress recommends spending, although that doesn't always come to fruition. So currently, the SLR grant is funded at $1.5 billion for all 50 states. Richard, I see your question. Is it the state who dictates where the money goes? It is your single state agency, very similar to your SAPT block grant. There's really no difference in terms of the grant's administration, in terms of the bureaucracy. Whoever handles your SAPT block grant, which is almost always your single state agency, they will handle the SLR grant as well. Same office does the application process, same office receives the funds. But you can see at the bottom there, it authorizes $2.7 billion. That is close to a 40% increase. Or actually, I'm sorry, that's closer to an 80% increase. From 1.5 to 2.7 is a significant increase. That is not necessarily a reality yet, but it's a recommendation. And it also wants to increase the minimum grant award to $12 million because right now states receive this based on population. California gets the most, Wyoming gets the least. I saw someone on here before from Wyoming, from Gateway, as I was reading through the people who have joined us this afternoon. And sorry, but Wyoming gets the least. I think it's Joseph. Wyoming gets the least because of the least populated states. Same way the block grant works. One thing about the SLR grant, if you are a state with one of the 10 highest overdose rates, you get a little bit more, a bonus. But right now, if you're a very low population state like Wyoming or the Dakotas or Vermont, you may not reach 12 million in terms of your funding. So this would increase them to a minimum of 12 million. Now you'll remember what the title of my presentation was, Full of Sound and Fury, Signifying Nothing. A lot of you may be looking at this and saying, wow, this legislation looks great. Well, guess what? The odds of its passing are probably less than 1%. Why? It has nothing to do, well, it has a little to do with Congress's appetite for this issue. It has to do in large part with the calendar. Congress has developed, comes as a shock to no one, a wonderful talent for kicking the can, we call it in DC. Here we are in December, and government funding, which was supposed to be finished by the end of September, still not done. So Congress does not have the bandwidth to handle every single bill introduced, obviously. But you would have hoped that an issue like the overdose epidemic, which is killing over 100,000 Americans every year, they might feel a little more urgent to act on this. But they haven't. So this bill's been introduced, but it hasn't passed. And odds are it will not. So great idea, great concept, something we support, and going nowhere. You can see, in terms of our advocacy, this is from the official press release of the SLR grant from the office of Senator Tammy Baldwin of Wisconsin. I didn't see anyone from Wisconsin on our call today. But Tammy Baldwin was one of the leads on this. And they asked for advocacy organizations to endorse this legislation. You can see there at the bottom, the Behavioral Health Association of Providers did endorse this legislation. So we're doing our part. You know, it's just, we're just not getting there. Is there an oversight? I have a question on SOR. Is there an oversight committee to monitor how the money is spent and its effectiveness? SAMHSA does an evaluation of this each year, and they break down how it's spent. I don't know if you call it oversight. They are required to report to Congress. I mean, Congress has oversight over anything they want when it comes to federal spending. If Congress wanted to call a hearing on this or demand a report on it, they could. SAMHSA does keep track of it. You have to understand this program is still in its infancy in large part. So we're getting there. But there is an effort underway to see how much is spent specifically on prevention, recovery, workforce, harm reduction, things like that. So there are efforts to track it. The ultimate oversight lies with Congress, but it's up to SAMHSA to do the tracking in real time, for lack of a better term. So I've been talking about a few federal grants, the SLR grant, the Star Loan Repayment Grant, but let's talk about that other thing I mentioned briefly before. SUD services, we live and die with Medicaid. In addition, believe we're up to 38 states that now use Medicaid Medicaid services to reimburse peers. So we need to really be aware of what Medicaid is doing. I just want to show you this graphic real quick. When it comes to advocacy and things we can actually influence, Medicaid's tough because Medicaid is a mandatory expenditure, which means I was talking about appropriations before. Anything that's appropriated by Congress, where Congress says this is how much we're going to spend, we can be advocates. We can say this program's good. You know, SLR, good. Star loan repayment, good. Block grant, good. We can send letters. We can do things like that. When it comes to Medicare and Medicaid, not so much, because those are mandatory expenditures. They come directly from the Treasury, and Congress does not have any authority to play with those numbers. It's formulaic. It's based on a formula. How many people are in need? What do the services cost? Here's the money. So now Congress can implement policies in terms of what CMS can and cannot do in terms of their guidance or trainings or what they should be exploring. But CMS is the Center for Medicare and Medicaid Services is part of the Department of Health and Human Services, but they really are a beast unto themselves. So we can't really advocate a direct change in Medicaid reimbursement amounts, but we can make clear to Congress that we'd like them to express to the Center for Medicare and Medicaid Services a need to do a deep dive into this. So all of the programs we advocate for, come to less than $6.7 billion. Now that sounds like a lot to many of you. In DC, it's not that much. It's really not, especially when you compare it to the size of other government agencies and what Congress spends on other issues, including in healthcare. Medicaid spent $23 billion last year for opioid-related treatment alone. That doesn't even touch other SUD issues. That's just opioids. So you can see how much bigger an issue Medicaid should be for us than these grant programs I'm talking about. Other policies that have kind of impacted us, telehealth. I'm sitting here talking to you coming out of my COVID illness, and what was one of the biggest changes we saw during the COVID pandemic? Telehealth. COVID changed everything in healthcare. And SUD was really no exception. Everyone wanted to know, what can we do with telehealth? And now that we're coming out of the pandemic, I won't say it's over because I'm still testing positive, but I won't say the pandemic's over, but we're coming out of it. What is going to stay and what is going to go? The concerns a lot of people have about telehealth are, the biggest concern is, can we cross state lines? During the pandemic, there was a lot of talk about, if necessary, yes, you can get help across state lines. Is that going to stay in place? With our workforce shortages, we wouldn't necessarily be opposed to that, would we? But when it comes to workforce, BHAP and other professional organizations are very, very serious about meeting certain standards. So we're not going to support anything that will allow anyone who is unqualified to provide services inside state boundaries or outside. We work closely with a lot of state associations. We work closely on a lot of reciprocity issues. And if there's going to be this, crossing of state boundaries in telehealth, we want to make sure the people providing the services are qualified. They are credentialed, whether you're in a state that allows credentialing, whether you're in a state that allows licensing, whatever it may be, we want to make sure you meet that high standard. So we keep a really close eye on what's going to be happening with telehealth. I've been talking about Congress quite a bit, and there's another aspect to government and policy, and that's the executive branch, the White House. And they have a role to play as well. You can see this goes back to May. The Biden-Harris administration issued a strategy to address the mental health crisis. Now, I know I've been talking in large part about substance use disorders because that's my expertise. Some of you may have expertise in mental health. Some may have an expertise in SUD. Some may cross over. In Washington and in policy, remember what I said before about behavioral health. There are those policymakers, i.e. many of them, I'd say the majority, who view SUD as a mental health issue, kind of like an outgrowth. Oh, when I say mental health, I mean SUD. That doesn't always benefit us. Sometimes it does, sometimes it doesn't, because it helps us qualify for certain programs. It includes us in certain programs. But if a program is thrown open to both mental health and SUD providers, there's nothing to say that the money or the attention is going to be divided evenly between those two problems. So we get a little concerned when we hear that something is being addressed as a mental health issue. Oh, and it also includes SUD. As you can see at the top of this slide, mental health and substance use disorders, all one word. Mental health and SUD often do go hand in hand, but they don't always. And we want to be sure that if someone presents with a mental health disorder, they're getting someone who can handle that single diagnosis if need be. And if someone presents with a substance use disorder, they're getting an expert who can handle that single diagnosis if need be. I don't buy that someone who's a mental health counselor can handle a patient with an SUD issue simply because MH and SUD are lumped together from a policy perspective. And this goes back to when Medicaid was written in the 60s, when SUD was considered a mental health disorder, even though that was the DSM-3 and now we're in the DSM-5, and that was the ICD-8, now we're in the ICD-10. There's been new definitions, new iterations, yet we're still stuck calling SUD a mental health disorder when it's not. It's got its own DSM-5 definition. So this is a really kind of tightrope to walk because you want to be included, but you want to make sure they get it right. That being said, talking about providers, the fragmentation and inconsistency of the current system can make it difficult for people to find the right level of care, and that you can all attest to. So at least the White House is aware of that. There was also a study done by the Bipartisan Policy Center, which I found really interesting. And this is something you can also find online. Just go to their website, Bipartisan Policy Center, and you can find this. I want to highlight, speaking of workforce shortages, remember what I said before. Remember HRSA said the shortfall by 2030 would only be 13,000. But a study just 2 years earlier by HRSA said the shortfall could reach up to 35,000. And the recommendation identified to address this shortage was the adoption of common standards of addiction education and increased availability of degree programs. Angie mentioned before that one of my clients is the IC&RC, and I'm very, very serious about standards when it comes to the workforce. So when there's a recommendation to, quote, adopting of common standards of addiction education, the industry, we have those standards. The IC&RC standards are widely accepted in the industry. It's the states that need to adopt the common standards. We don't have uniformity amongst the states. A doctor is a doctor is a doctor, but it's the state that says you're a doctor. Rhode Island can change their laws on who's a doctor tomorrow. They won't, but they can. But right now in all 50 states, it's pretty much the same. A degree in medicine, MD or osteopathy, and board certification. We don't have that uniformity in the states. So it makes it difficult for us to advance as a profession without that uniformity. So adopting of those common standards, it's not for us as a profession that needs to do it. It's the states that need to do it. Richard, I see your question. I'm going to address it in just a minute. Another report was from the Senate Finance Committee. Now, remember back to that first slide, full of sound and fury, signifying nothing. How many reports am I going to read this year about what we need to do and then watch nobody do it? The answer is many. So the Senate Finance Committee produced a very long report, and they produced 5 different bills based on this report. Whether or not they will become law, we'll know within the next 2 weeks. Again, the Senate Finance Committee addressed workforce shortages. Again, they cited the Health Resource Services Administration. Okay. HRSA projects the shortage to reflect insufficient adult psychiatrists and addiction counselors in 2030. Okay. Here's why I want to point this out. Remember, I was talking about behavioral health before. In Washington and in advocacy, whenever there's money available, everyone's going to come running. And they're going to kind of phrase the problem in a way that is in the best light to them. So when you see that we have a, quote, behavioral health workforce shortage, everyone's going to come running. Social workers, marriage and family therapists, licensed professional counselors, psychologists, their professional associations are all going to say, we want a piece of that. We want a piece of that. And why not? You know, that's what advocates do. I do the same thing. Okay. So that's the danger in using terms like behavioral health. If you say there's a behavioral health workforce shortage, everyone who can define themselves as a behavioral health association is going to say, invest in our profession, invest in our profession. But the numbers say the only real shortages are in psychiatrists and addiction counselors. Now, if you're a social worker or a marriage and family therapist and you're an LPC and you're on this call, I'm not disparaging you. I'm not disparaging your profession. I'm not disparaging your professional association. I'm saying this is what the data says, right? This is what the data says. And the Senate Finance Committee put this in their report. And when the Senate Finance Committee produced a bill on workforce, what bill did they produce? What professions did they say should benefit from changes in Medicare? Marriage and family therapists and licensed professional counselors, where no study says we need an increase in those professions. The increase is needed in psychiatrists and addiction counselors in their own report, yet the legislation didn't reflect that. You know, why? Because 10 years ago, someone wrote a piece of legislation that would benefit marriage and family therapists and LPCs, and they dusted it off and said, here's our legislation. Full of sound and fury, signifying nothing. Sorry if I'm putting you in a bad mood, but it's not exactly a great time of year here in DC. There's also a very big push at the policy level on primary care. A lot of policymakers want to see SUD treatment integrated into primary care because they believe this is how it will reach more people, which means it means one of two things. It means either training primary care professionals in SUD, or it means placing our professionals in primary care settings. It's going to be one of those two. I know that physician's assistants, for example, now brag, oh, we get SUD training in as a physician's assistant. Want to know how much? 2 hours. Okay, that's not training. You know, if I break my ankle and I need to go see a doctor, I'm not going to my oncologist. I'm going to my orthopedist. You know, if I have leukemia, I'm not going to my nephrologist. You know, I'm going to my oncologist or hematologist. You go to the specialists. If policymakers are serious about primary care integration, they will do more to make sure our professionals are placed in those settings. Okay, but that means standards will have to be met. Remember what I said before about standards in education and in training. We're going to have to make sure our standards are met across the board when it comes to our professionals. HRSA has grants for integration, as you can see here. I'm going to speed it up a little because I'm coming to the end of my presentation. But here's to show that HRSA is serious about promoting integration. They have a fellowship program, and their fellows receive training in health equity, opioid use treatment, and substance use treatment. Yeah, they receive training. I don't know how much. Most states, for their highest level of SUD professional, require thousands of hours of training. So the devil's really in the details in regards to this. There's another training for physician's assistants, like I said. So they receive training in, quote, substance use treatment, 81%. Like I said, they receive 2 hours. No, it's not good enough. This is probably a good time, Richard, to answer your question. Richard asked, how do you fight against those causes, that get national attention, like global warming and infrastructure? Why isn't this issue getting national attention? I wish I had the answer. It comes one single word, and that's probably stigma. Let's look at it in the frame of healthcare. No one will say to a cancer patient, you brought this on yourself. No one will say to someone with lupus, you brought this on yourself. No one will say to someone with diabetes, you brought this on yourself. Yet they will say that to someone with a substance use disorder problem, even though it's wrong. This disease is misunderstood. I was on a social media page talking about an athlete whose career was derailed by drug and alcohol use, and I said he had a disease, and you should have seen the responses I get. No, he doesn't, blah, blah, blah. They said, if he had, they're like, this isn't the same as cancer. I said, well, tell me something. If someone's a chain smoker and they get lung cancer, did they bring that on themselves? Maybe they had an addiction to tobacco, but if someone, had unprotected sex and contracted HIV, they still got the disease, but did they bring that on themselves? Yet, there's this misconception of what the disease of addiction is and what a substance use disorder is. Too many in society are not willing to accept the disease model. And that's a simple answer. Richard, Congress is a reflection of the people, plain and simple. I have always believed you will never get anywhere educating Congress unless you're educating the general public at the same time. So this outcry that we saw 5-10 years ago over overdose deaths, Congress only addressed it because their phone started ringing off the hook, not because they were so greatly concerned. You make the phones ring off the hook, Congress will act. So, the simple answer to your question is we are still a very misunderstood disease. And until people understand the disease model and understand that people with a substance use disorder didn't bring it on themselves, it's going to be a struggle. Skip that. I'm going to close with just a few points about some of the big policy issues also being discussed. Medication-assisted treatment. There's been a lot of talk about buprenorphine and methadone this Congress, about changing regulations. I was talking about changes brought about by the pandemic. One of the changes brought about by the pandemic is that methadone regs were changed. Take-home methadone was allowed and mobile methadone clinics were allowed. And then that was extended for 1 year, set to expire in March 2023. We're seeking to make those permanent. If you want to talk about policies that are antiquated, I give you methadone. So there's even actually an effort for not over the counter, but prescription methadone to be filled at local pharmacies so people don't have to make that trip every day. So MAT is a very big policy issue right now. I'm going to actually skip that because we're running out of time. There's also the MAT Act, which I'm going to get to in a minute. MAT Act. The MAT Act is a piece of policy that we've been talking about for, coming up on 10 or 12 years now. And this would end the cap on buprenorphine prescribing. As many of you know, there's something called the X waiver, which limits the amount of buprenorphine that can be prescribed by a doctor. This would lift that. Now, the data says that buprenorphine is the very large percentage is still prescribed by very few prescribers, and that may be the case. But passing the MAT Act would be a victory. There are not a lot of moral victories in Washington, but this would be, because here's why. You mean to tell me a doctor can write thousands, if not millions, of prescriptions for Percocet or OxyContin, but they're limited in the number of prescriptions they can write for buprenorphine? Mic drop. No. So, you know, for years, law enforcement has said they're afraid of diversion of buprenorphine. Well, if you want to talk about diversion, let's talk about OxyContin. So we're really hopeful that the MAT Act might be able to pass. Finally, you can't really only talk policy without talking politics. I tell people all the time what you see on the news, whether you watch CNN, whether you watch Fox, whether you watch MSNBC, whether you watch C-SPAN, what you see is politics, the big stories, immigration, Ukraine. That's politics. 99% of what I deal in is not politics, it's policy. Okay? But politics does influence policy. We now have a new party taking over the House. We have the GOP. The Senates have remained in Democrat hands. What changes can we expect? I think the House is going to be focused on fentanyl, much more so than they have in the past. But I think it's going to be from the standpoint of the border and interdiction. I'm seeing a trend in Republican communications that their focus is to blame President Biden for the fentanyl emergency by blaming, quote, open borders. This is not true. I'm not being political. I'm being factual. A high percentage of fentanyl comes through legal ports of entry and through shipping containers, not the border. So, but that's where we're going to see a lot of focus. How that translates into policies concerning treatment, we're not quite sure yet. I have one last question from Joseph. What are your thoughts on the utilization of certified peer specialists in the SUD field? I'm going to answer that very quickly. Joseph, I think peers are playing a huge role, but I see two potential pitfalls. Not pitfalls, two potential mazes to navigate. One, standards. I see mom and pop shops popping up all over the place saying, take our weekend class and be a peer. I'm not buying it. Like I said before, standards are important for our profession. I would say 50 to 60 hours is fair. If you're going to reimburse Medicaid, you better have standards. So one, I want to see uniform standards for peers. If you're going to be taken seriously as a health professional, you better meet standards. Two, I think the peer workforce is going to become almost its own universe in workforce. Because right now, remember what I said before about behavioral health workforce. That's a big universe. You know, even just in SUD, I've got prevention specialists. I've got bachelor's level treatment. I've got master's level treatment. I've got clinical supervisors. I've got, you know, it runs the gamut. It's not all the same. So, and then you add peers to that. But the reason I think the whole peer issue is going to almost spawn its own workforce universe is because we're going to need peer supervisors. We're going to need family peers. The word peer in and of itself is loaded. Who is a peer? What is a peer? Veterans, special populations, you know, am I your peer if I've gone through the same experience as you? Yes. But if you've been in combat and I haven't, am I the right peer for you? If you're from the city and I'm from the farm, am I the right peer for you? You know, so there's a lot more in the peer universe that we're going to have to navigate on the workforce, especially when it comes to peer supervisors, when it comes to family peers, and when it comes to special populations. So there's a lot to do in the peer space. It's almost going to be like its own, if I were to say the primary care workforce, well, geez, that's doctors, nurses, nurses assistants, physicians assistants. There's a lot of different professions in there. I think SUD is the same, and I think even peers is the same. So there's a lot to do in that space. Thank you for that question. I think peers is going to be a really interesting issue going forward for the workforce. We need to wrap up because I can't talk anymore, and we're at the hour. So the beauty of advocacy is we start all over again in a few weeks. Every January, new Congress, boom, start over. Kind of like a Groundhog Day that lasts 2 years. So we get to start all over again in January. But that's the nature of advocacy. And hope does spring eternal. We measure our progress very, very incrementally. If you want overnight results, advocacy is not the field for you. A very hard lesson I learned when I started 23 years ago, if not more. I forget. I may be older than I look. I've been in this town for 28 years, and you just keep grinding. You just keep moving forward, and BHAP is a part of that process. I hope you all enjoyed the webinar. I hope you enjoy your BHAP membership. We've worked very hard to make this a service for you that is worth your time. I want to say two things to everybody. Get your Omicron booster if you can, and please enjoy a safe and peaceful holiday season with your loved ones. Thank you all, and I'll see you again in a few months.
Thank you to Andrew Kessler for presenting today. Thanks as well for you for participating. We hope you join us for future BHAP webinars. You can sign up for our various newsletters, which includes emails specific to upcoming events at our webinar website, www.bhap.us. With that, this concludes today's webinar. Thanks again.